Hello everybody. Over the next few minutes, we'll discuss the current state of the MRI-directed pathway, focusing on men in the early cancer detection setting. These are my disclosures. You'll see that I may include discussions on the non-guideline use of MRI. So, over the next few minutes, I'll give you an update on the performance characteristics of the current version of PI-RADS. I will distinguish the pathway benefits of the MRI-alone pathway from those of a risk-based pathway, which additionally considers PSA values. I will discuss the prerequisites for an integrated MRI-based prostate cancer diagnostic pathway and show you a new way of assessing the clinical benefits and harms of any pathway in the era of biopsy avoidance. The prostate diagnostic MRI pathway is used for risk assessments before biopsy decisions and for biopsy planning. We can distinguish two pathways, one of which is based on MRI alone and another that additionally considers the clinical risk. In the MRI alone pathway, men with negative MRI scans avoid biopsy, and men with positive PI-RADS 3-5 category scores undergo a biopsy. No other risk assessments are considered for biopsy decisions. On the other hand, a risk-based pathway usually includes an additional clinical risk assessment, typically by considering the PSA density. Men with a negative MRI and a high PSA density would usually undergo a systematic biopsy. Men with indeterminate PI-RADS 3 category scores, who are at higher risk based on their PSA density, would also undergo a biopsy, as would all men with PI-RADS 4-5 category scores. In both pathways, there is a safety of monitoring for men who avoid an immediate biopsy after a negative MRI. So what are the benefits of the MRI-alone pathway in an outpatient urological population, where approximately 1 in 3 men have clinically significant disease? Number 1, you will see a reduction in the number of men undergoing a biopsy. In the vision analysis of 2 prospective randomized studies, we can see that about 32% of men avoided a biopsy. Number 2, it reduces the diagnosis of indolent cancers. In the vision analysis, there was about a 12% reduction in the detection of GG1 cancers. There is superior detection of clinically significant cancers. Approximately 9% more grade group 2 cancers were detected. MRI enables more accurate and targeted biopsy cores, with a higher percentage of cores yielding positive results. So we have 4 main pathway benefits. Remember that benefits come from true results, but we have to bear in mind the harm which can arise from false results. So, false positives and false negatives. False positives result in unproductive biopsies and overdiagnoses of indolent cancers, which can lead to overtreatments due to the emotional label of cancer. This is highly variable between studies. On the other hand, false negatives result in missed cancers and delays in treatment, which is relatively consistent between studies, usually below 10%. So, the essential prerequisites for a successful diagnostic MRI pathway include appropriate patient selections, PI-RADS-based imaging interpretations, the quality of the radiological processes, biopsy, decisions that take into account clinical and patient preferences, and having processes for ensuring the oncological safety of men who avoid an immediate biopsy after a negative, good quality MRI. Let's consider each one of these in turn. The MRI pathway is primarily meant for asymptomatic or symptomatic men with a reasonable life expectancy after their initial clinical risk assessment according to the 2024 EAU guideline. Multiple patient groups are eligible for the MRI pathway as defined in the EAU and NCCN guidelines. Typical patients include average or high-risk men, clinically selected, biopsy-naive, with a normal DRE and an elevated gray zone PSA, typically between 3 and 20 nanograms ml. Another group are men with a persistently elevated clinical risk of having clinically significant cancer despite a prior negative or non-explanatory initial systematic biopsy. However, there are fewer of these men nowadays, and increasingly we see men who experience progressive PSA kinetics or have worrying clinical findings when on a safety net of monitoring after a previous negative MRI who avoided a biopsy, or men who had a positive MRI and negative histology. Another important prerequisite is PI-RADS-based image interpretations. This is because the higher the suspicion score on the PI-RADS scale, the greater is the prevalence of clinically significant disease. As you can see here in red, patients with negative MRI scans, PI-RADS 1 and 2, have a low prevalence of clinically significant cancers, defined as grade group 2 and above. It's between 5% and 6%, but there's a stepwise increase in the prevalence of GG2 plus cancers, ranging from 19% for PI-RADS category 3 to 84% for category 5 cases. Next, let's talk about the quality of the radiological processes. The most important is a PI-RADS compliant imaging technique. Every MRI report should include a quality assessment using the PI-QoL scoring system, with each scan being scored as inadequate, acceptable, or optimal. Ideally, radiologists who review these scans should be adequately trained, with relevant experience and qualifications, and increasingly utilize AI systems. There is an increasing need to think about certifying radiologists. When biopsies are needed, centers should be equipped to perform them, or at the very least refer patients for biopsies. Any biopsy should target the MRI-detected lesion with additional perilesional cores if you practice in Europe or systematic cores if you practice in North America. Ideally, patients should undergo MDT review, and multidisciplinary team working, including pathological feedback for radiologists, is essential. Finally, MRI centers should be designated and accredited, and they should ideally monitor their key performance indices. The next thing we need to take into account is urological and patient preferences regarding biopsy decisions. Remember that there's a spectrum of patients who come to urological clinics, ranging from patients who are cancer-averse to patients who are biopsy-averse. The key feature of a cancer-averse patient is that they are very concerned about a cancer being missed, even low-risk cancers. These patients include younger men with raised PSA, men with a strong family history, black ethnicity, or known germline mutations. Typically, these patients, when seen in early detection settings, have a higher prevalence of clinically significant cancers, usually between 30% and 50%. Here's an example of somebody who is cancer-averse. Why is he cancer-averse? Look at his history. His PSA is raised, his PSA density is elevated. He has a father who had prostate cancer, and he is of Afro-Caribbean descent. So, a classical cancer-averse patient. His scan shows a focal PI-RADS 3 lesion in the left peripheral zone. He needs a biopsy targeting this area. A man like this has a low tolerance for missed cancers, a lower concern regarding biopsy harms, and a greater tolerance for overdiagnosis. He is more likely to accept some harms of the diagnostic pathway. On the other hand, biopsy-averse patients are more concerned about biopsy complications and less concerned about missing lower-risk cancers. Typically, these include older patients and patients with comorbidities. They have a higher tolerance for a small, missed cancer. They seem to be more concerned about bleeding, infection, etc., and they want to avoid biopsies and the diagnoses and treatment of insignificant cancers. Another subgroup of biopsy-averse patients is men seen in primary screening settings with an intrinsically lower disease prevalence. The prevalence of disease is typically 4 to 10% when MRI is performed as a primary screening method, and about 20% if screening MRI is done after a PSA test. Here is a biopsy-averse patient, a 74-year-old physician, PSA 0.75 nanograms ml. Brother died of prostate cancer at 84 years old. So there is no elevated risk factor for prostate cancer. Best not to do an MRI at all. New pain in the right leg, and so was referred for a pelvis and prostate MRI. The radiologist reported a PI-RADS 5 lesion in the transition zone, perhaps pushed by the AI due to human susceptibility from automation bias. Unfortunately, all 27 biopsy cores were negative, with 5 transition zone cores showing only chronic inflammation. His only risk factor was that he was a doctor. An important point to consider is how we assure the oncologic safety of men who avoid an immediate biopsy after a negative MRI and clinical assessment. Again, this depends on the underlying risk, with men at higher risk being monitored more frequently and by urologists, whereas those at relatively lower risk are managed in the community. It's essential that the roles and responsibilities of carers are well defined, and we, as radiologists, help define triggers for re-imaging. This is essential to control our workload while balancing the benefits of early diagnosis against any possible harms caused by patient scheduling anxieties or PSA. This leads us to think about how the overall pathway benefit can be objectively assessed against the harm. In the modern era, where many patients do not undergo biopsy, we need to rethink the metrics that we use to assess the benefits and harms of the MRI pathway. We can no longer rely on our traditional sensitivity and specificity metrics. Given that histopathological verifications are not available in many cases, we need to focus on benefits and harm in men undergoing biopsy and in those avoiding biopsies. Some of these benefit-to-harm ratio metrics are shown here. So for men who undergo a biopsy after a positive MRI, we can compare the detection of grade group 2 plus cancers with indolent cancers, and that would tell us about biopsy grade selectivity. In other words, a higher GG2 plus GG1 ratio means that of the cancers detected, more cancers with grade group 2 compared to those with grade group 1. Another metric we could use is the significant cancer detection efficiency. This is measured by taking the number of grade group 2 plus cancers and dividing it by the sum of patients with unproductive biopsies and grade group 1 cancers. Using this metric, a higher ratio indicates a more efficient biopsy approach for detecting grade group 2 plus cancers. For men who avoid a biopsy after a negative MRI, we can consider how selective the avoidance is. We do this by comparing the number of avoided biopsies, GGX after negative MRI results, to the number of unproductive biopsies in men with positive MRI. A higher ratio indicates that more men avoid unnecessary procedures while minimizing the rate of unproductive biopsy procedures. We have already learned that the proportion of missed cancers when biopsies are avoided is less than 10%, varying little between studies and centers. Let's see how these metrics work in practice. Here is the author meta-analysis that I showed you earlier. If we took just the PI-RADS 5 category, you can see that 84% of people in this category have clinically significant cancers. And you'll see that 16% of men would have either GG0 or GG1 cancers. So the clinically significant prostate cancer detection efficiency is 5.2. Remember, we take the GG2 plus cancers divided by the unproductive biopsies, that is, those yielding GG1 lesions and benign GG0 histology. Now, let us apply this formula across each of the PI-RADS categories or different biopsy cutoffs. The GG2 plus prostate cancer detection efficiency is shown on the right-hand side. The grade selectivity is shown on the left. Remember, grade selectivity refers to the ratio of GG2 plus cancers to GG1 cancers. As expected, the higher the PI-RADS score, the greater the selectivity towards grade group 2 plus cancers. For example, PI-RADS 5 has a GG2 plus GG1 ratio of 10.6, much higher than PI-RADS 4, which is 2.6. Similarly, you can see that if you took a PI-RADS 3 to 5 cutoff and compared it to a PI-RADS 4 to 5 cutoff, then the PI-RADS 4 to 5 cutoff has greater grade selectivity, 4.6 versus 2.7. On the right-hand side, you can see the GG2 plus detection efficiency. To recap, this is the number of grade group 2 plus cancers divided by the sum of the number of unproductive biopsies and the number of grade group 1 cancers detected. As you can see, the CSPCA detection efficiency increases with the PI-RADS score and varies according to the cutoffs used. So, the efficiency is greater for PI-RADS 4 to 5, 2.2 compared to PI-RADS 3 to 5 when it's 0.8. So let's just apply these ratios to the MRI-alone pathway. The vision analysis was a case-level analysis of 2 randomized controlled studies comparing systematic biopsies in all patients versus targeted biopsies only in men with positive MRIs. These studies were the precision and precise studies. You can see that grade selectivity is higher for the MRI-alone pathway. In other words, there are many more grade group 2 plus detected for every grade group 1. The MRI-targeted approach is 2.9 times more effective in men with positive scans than systemic biopsies, also demonstrating greater grade selectivity. Similarly, the GG2 plus cancer detection efficiency is 3.3 times higher. And of course, because 32% of men avoided biopsies after an MRI, the selective avoidance ratio of the targeted MRI approach is also much greater, 9.5 times higher than systematic biopsies. So you can see that these ratios nicely capture the benefit to harm ratio in the diagnostic setting for the MRI-alone pathway. So let's apply these metrics, these ratios, to the risk-based pathway and compare the performance against the MRI-alone pathway, where every man with a PI-RADS 3-5 lesion has a biopsy. In the risk-based pathway, men with a negative MRI but an elevated PSA density greater than 0.2. Get a systematic biopsy, men with a PI-RADS 3 with a PSA density greater than 0.1. Get a targeted plus perilesional biopsy or systematic biopsy, and all men with PI-RADS 4-5 get a targeted and perilesional or systematic biopsy. So, what would be the benefit to harm ratios of the risk-based pathway compared to the MRI-alone pathway? This is aggregated data from 6 studies involving 4,643 patients. Note again that the GG2 plus prevalence is approximately 30%. We are comparing the benefits and harms of this pathway against the MRI-alone pathway, where all men with PI-RADS scores of 3 to 5 get a biopsy. Looking at the grade selectivity, cancer detection efficiency, and selective biopsy avoidance, the results are almost identical. So what is the point of the risk-based pathway? Well, look at the detection odds for GG2 plus cancers, that is, the true positive to the false negative ratio. You'll see that it is greater for the EAU risk-based pathway 18.9 compared to the MRI-alone pathway 16.5. So, what we can say is that the risk-based pathway is more personalized because it takes into account an individual patient's risk by using both the PI-RADS category score as well as his PSA density, and that overall this strategy has better benefit to harm ratios, particularly for the detection odds for GG2 plus cancers compared to the MRI-alone pathway. So, these are my final concluding remarks. A successful pathway consists of 3 pillars: risk-based thinking, MRI optimization, and clinical integration of MRI findings. For risk-based thinking, you need to consider the type of patient you have in front of you. Is it for early detection or population screening? We need to take into account an individual's clinical likely preferences regarding biopsy decisions, depending on their aversion to biopsy or cancer detection. What do they prioritize? The MRI procedure needs optimization. This is done by conducting PI-RADS compliant scans, with quality-assured reading supported by radiologist training and certificate ION. We need automation of processes to minimize variations. AI will be increasingly used, particularly for inexperienced users. There will be some personalization of protocols regarding the need for contrast medium, reading criteria, and biopsy indications, as well as how lesions are targeted. The clinical integration of MRI findings into biopsy decision-making will require multidisciplinary teamwork, MRI-based targeting, and the deployment of methods to ensure oncologic safety with safety nets. All the while, we must ensure that we have a pathway that is quality assured with monitoring of KPIs, including the monitoring of benefits and harm of the chosen MRI risk-based pathway. Thank you very much for listening. I hope you found some of these comments valuable for your clinical practice.